Well, hello and welcome to this month's CSF podcast. As always, aiming to keep you up to date with the latest information and data in the world of rheumatology. And what a great world that one is. And today I'm going to review two papers that investigate different JAK inhibitors. First paper comes from Professor Roy Fleischmann and his colleagues, and it compares the incidence of serious adverse events in RA patients with a higher risk of cardiovascular events and the overall RA population in a post-hoc study. They've also compared the incidence and rate of adverse events for upadacitinib, adalimumab, and methotrexate or methotrexate monotherapy. And then in our second paper, Mohammed Khan and his colleagues compared tofacitinib against methotrexate as first-line therapies in people with rheumatoid, with a focus, interestingly, on treatment remission, how times have changed that we're focusing on remission. It's marvelous. And as always, if you want to look at the detailed summary slides of the papers discussed today, head across to cytokinesignaling.com, a veritable treasure trove of incredibly useful information recommended to you. Okay, so first paper, safety profile of upadacitinib in patients at risk of cardiovascular disease, integrated post-hoc analysis of the SELECT phase 3 rheumatoid arthritis clinical program. Now, the background, I think all of us are aware now that oral surveillance reported an increased risk of SAEs for tofacitinib relative to TNF inhibition in patients with RA aged more than or equal to 50 years enriched for cardiovascular risk. On the other hand, we've seen very strong evidence for efficacy and general safety of the JAK inhibitor upadacitinib, and this has been evaluated in a broad range of phase 3 trials, the SELECT clinical program, and that included SELECT Compare, long-term head-to-head studies of upadacitinib versus adalimumab, and SELECT Early, upadacitinib versus methotrexate. So this paper describes a post-hoc analysis of 6 phase 3 trials. It examines upadacitinib versus adalimumab and methotrexate monotherapy to see whether adverse events of special interest occur more frequently among patients with elevated risk of CV events and assess relative risk of those events. So patients received in SELECT Compare upadacitinib 15 milligrams once a day with or without conventional synthetic DMARDs, or adalimumab 40 milligrams every other week with concomitant methotrexate. And in SELECT Early, this was methotrexate monotherapy. 3 populations were assessed for adverse events of interest. The overall population, patients with higher CV risk from the overall population, and patients with higher CV risk specifically from SELECT Compare. So 3 different starting points when you start to think about the numbers we'll think about just in a moment. Exposure-adjusted incidence rates for treatment-emergent adverse events were summarized based on exposure to upadacitinib or the relevant comparators. So what are the key results? Well, across the 6 studies, 4,102 patients were enrolled. Baseline demographics were broadly similar between the treatment groups, and baseline characteristics suggest that patients in methotrexate monotherapy were DMARD naive and had a shorter amount of time since diagnosis compared to other groups. Hypertension was a more frequent risk factor in the higher cardiovascular risk population. There were similarities between treatment groups in all demographics, but they were more frequent in higher risk cohorts for the following exposure-adjusted risk factors. First, adjudicated MACE. Secondly, malignancies, excluding non-melanoma skin cancer. And thirdly, adjudicated venous thromboembolism. The exposure-adjusted incidence of serious infection was higher with upadacitinib 50 milligrams, but this did not achieve statistical significance. Exposure-adjusted incidence of herpes zoster was significantly higher in all demographics, except the SELECT Compare higher risk CV population group for upadacitinib. Rates of NMSC in all populations were higher with upadacitinib 15 milligrams than with comparators. So what do we conclude? Well, an increased risk of MACE, malignancy, and venous thromboembolism was observed in higher risk populations of rheumatoid, yet this risk was comparable between upadacitinib treated and adalimumab treated patients. Higher rates of non-melanoma skin cancer and herpes zoster were observed with upadacitinib versus comparators across all populations, and increased rates of serious infections were detected in upadacitinib treated patients with a higher cardiovascular risk. Okay, so one further analysis. I think we need to see this in the context of a much wider emerging literature, including real-world data, and this is an ongoing work in progress, but very helpful to see this description of these data sets. Second paper, tofacitinib versus methotrexate is the first-line disease-modifying antirheumatic drug in the treatment of rheumatoid arthritis, an open-label, randomized, controlled trial. So I think tofacitinib now needs no formal introduction. It's an efficacious medicine in the treatment of rheumatoid arthritis. Both ACR and EULAR recommend its use in people with moderately to severely active RA and an inadequate response to our intolerance to methotrexate. There are some qualifications around the timing of when JAK inhibitors might be introduced into the treatment paradigm, and just bear that in mind. When used as monotherapy, it was superior to methotrexate in reducing signs and symptoms of inflammation, inhibiting progression of structural joint damage, and improving physical function. There are no published data directly comparing tofacitinib 10 milligrams to methotrexate 25 milligrams subcut as first-line DMARD. And this study compares the efficacy and safety of just that combination, or I should say comparison, in patients with RA with high disease activity who had not received methotrexate or tofacitinib or therapeutic doses of these drugs in the past. 100 patients were randomized 1-to-1 to tofacitinib, 10 milligrams, 49 patients, or methotrexate 25 milligrams per week, 51 patients, over 12 weeks. And the primary endpoint was achieved low-dose disease activity in the DAS28, ESR, and or CRP measures. So the key outcomes, well, the majority of patients were female. Mean age was 41.9 years in the TOFA group and 44.6 years in the methotrexate group. Median disease duration was 5 years for the TOFA and 3 years in the methotrexate group, which is pretty high when you think about it. The percentage of patients who used to smoke was similar in both groups. There were no significant differences between the groups in terms of tender joint count, pain, physician, patient's global assessment, function, DMARD naivety or previous DMARD use, and seropositivity. The swollen joint count was higher in the tofacitinib group compared with the methotrexate group, and that achieved significance. There was no significant difference in ESR and CRP between the groups. Among the composite measures, baseline DAS28 ESR, DAS28 CRP, and SI were the same between the groups. 14 tofacitinib and 11 methotrexate patients achieved LDA by DAS28 ESR, but this was not significantly different. There was no significant difference in achieving LDA between treatment groups using other outcome measures, DAS28, CDI, and SI measures. And composite measures and functional status decreased within groups, but not between the different groups in terms of any significance. The total number of adverse events was 13 in the TOFA group and 21 in the methotrexate group. 5 TOFA patients developed hypertension. Methotrexate caused GI problems in 12 individuals, which were less frequently observed in the tofacitinib group. The 2 methotrexate and 2 tofacitinib patients had increased liver enzymes and renal impairment, respectively. Tofacitinib had 5.4% infection compared with 5% for methotrexate. So taken together, not a lot to differentiate these two approaches, but I would note that 10 milligrams of tofacitinib is probably not a dose that we're likely to be using anytime soon. And I would also caution against the wider safety profiles that we're thinking very carefully about in terms of JAK inhibition, and also about the order and timing of targeted synthetic DMARD use, which is tending to be reserved for later application, according to, for example, the recent EULAR recommendations for the treatment of rheumatoid arthritis. So again, more data to inform us, but I think important to see this in the wider context. Well, as ever, if you want to view the publications uploaded this month and access our other podcasts and resources, head across to cytokinesignaling.com. And as always, Thanks for your attention. Don't forget to subscribe to the podcast on iTunes or Spotify, or indeed anywhere that you get your podcast media from. And do please let us know what you think by leaving a review. The podcasts are really there to try and help us all to manage our patients as well as we possibly can. And I'd like to hear from you to know how we can do that as well as we possibly can. So that's just great to have the chance to chat with you again. Looking forward to the next one, and meantime, wishing you well.